My name is Rosie. I'm here with Josie and Mikhail, and we're really happy to be here at the Royal College of Physicians today as part of the Action on Medical Health Inequalities. So we're here to talk a little bit about our training experiences around social determinants of health. So just to start with introductions, I'm ST3 in paediatrics. And I work in North London at various different hospitals, and I have an interest in health inequalities and particularly adolescent health and safeguarding.
I'm Josie. I'm a final year medical student at St George's University in South London. It's great to be here and have this conversation with people in clinical practice to hear about where our learning can take us in tackling health inequalities.
Hi, my name is Mikhail. I'm one of the junior doctors working at University College Hospital. I did my undergraduate degree at Newcastle University and then studied medicine at Barts. And yeah, it's great to be here to have these discussions with everyone.
Great. So I guess for me, it's now quite a few years ago, but I was just interested with you guys, with it being a little bit more recent, what has been your experience about learning about social determinants of health and health inequality at medical school?
Considering I was just about to leave medical school, I think I'm quite knowledgeable about what medical school can currently offer in terms of teaching about health inequalities and different social determinants of health. At my medical school, we're privileged enough that the community has kind of grown around the medical school, so we regularly have demographic changes in our patient population, and I think the medical school has been very good at adapting the medical curriculum in helping us understand about how social determinants can really impact different people's health. So we'll regularly have conversations with patients day to day, or kind of impromptu classes about how to communicate with patients about different aspects of their health and how that relates to their health behaviours. I think throughout the 4 years at St George's, we've been exposed to quite a fair bit. For example, we've had several talks or external educators come in to talk about their research with social determinants of health, but also in our vivas and OSCEs at the end of the year where we're assessed, we're kind of asked to take into account the whole of the patient's background in considering what's the best management plan for the patient to fit them. And I think that really puts our best foot forward in how we're going to move into clinical practice. So I feel very prepared to have these kind of conversations with patients and with other doctors about how patients' social circumstances really influence their health. I don't know whether that kind of is carried on in F1.
Yeah, I guess I've also recently graduated and we had quite a few individual days where we'd talk about, we'd have a specific day talking about social determinants of health. I think in my 4th year in particular, we had these 3 set days where we'd do some reading, we'd look at the Marmot Review, for example, and listen to some podcasts and some YouTube channels, and then we'd come in like a group discussion and talk about things. And I mean, like, you hear these ridiculous statistics that black women were 5 times more likely to die in childbirth, and I think it's black men were almost 4 times more likely to die of COVID, and like those are the statistics that we learn, and they're quite startling as well. And then growing up in East London is where we studied. We spoke about like Chicken Shop Mile, which is Mile End Road, has got one of the highest densities of like takeaways and chicken shops, and you can get 2 wings and chips for 99p there. And I think we spoke about like free school meals and how if free school meals were stopped, that was a big discussion at the time, and how that's a cheap option for people to go and get some sustenance. But obviously it's not the healthy options, and I think that really contributes to this like social economic disparities, I think.
Yeah, I wonder how much things have changed in even the kind of 5-6 years since I left medical school, because I remember while it was discussed, it wasn't kind of one of our core things. We had medical sociology, but the focus on that wasn't social determinants. It was more kind of, about the relationship and that sort of dynamic. And we had a lot of informal teaching, which was almost kind of organised between the students, those people who maybe have a particular interest in health inequality or inequity. And it kind of manifested in that way, in addition to the more formalised learning. Has that been something you guys have managed to do at university? Did your own kind of interest manifest in that way?
Currently at St George's, we have an amazing programme where if any medical students find a lacking in the course, particularly around the social side, in understanding patients better. We are able to write a recommendation and ask the university to kind of make a pilot program and implement this into the course. So the course is changing in real time to kind of fit what we want to learn and we feel like is really important for future doctors to know. And I think this is an incredible program going forward that other medical schools should also consider implementing, because it's letting future doctors, medical students, lead the change that they want to see in terms of how to operate in the NHS. So I've been lucky enough to kind of champion my own pilot program from year one about small group learning, but I have colleagues as well that really focused on health disparities between races. For example, Mind the Gap was made at St George's University, where it described about the health disparities in different kind of dermatological presentations, and that's been made into a textbook for medical students to see different presentations across different skin colours, and that happened within the university. So I think when universities give a voice to students, they kind of talk about what they want to learn, and I think it's good to lead that kind of change. Did you see that at your university as well?
Yeah, I think I remember during COVID, that's when this whole Mind the Gap thing came up and people were talking about decolonising curriculums everywhere, and I think that was like a really great resource. And I think we didn't specifically have any sort of individual student sort of run courses where we were to do that, but I think you were mentioning something, weren't you?
Yeah, well, when I was at university, me and a couple of friends noticed a real lack in terms of teaching on sexual violence that had been experienced by patients, and then helped kind of advocate for that to be taught as part of the curriculum. And I think, you know, as you were saying with your thing, there's so much that can be learned from medical students. You know, everyone is their own kind of human. We're not just a medical student and come with their own experiences and their own biases, and you know, bringing their experience as part of the curriculum can really kind of benefit everyone.
I think that's a really good point. Now medical school is becoming more diverse in terms of the backgrounds of its students. They have their own information and experiences of health inequalities faced by their family members or possibly faced by themselves. And when they bring that forward to the course, it's going to be an experience that's shared, and you're going to carry that through into your own clinical practice. Do you have any experiences of that?
I guess, yeah, the discussions, I mean, on the sort of days that we did where we'd speak about these things, I think learning about social inequities in health it's really important to have those discussions, because you can sort of, a lot of medical learning is learning facts and you're just revising for these exams, but I think these aren't hard and fast, there's not right and wrong with the social determinants, and I think the best way to sort of look into them is have these group discussions where when you're really discussing something, I think you formulate your own views and you have to be a bit more confident in what you're saying. So I think that's the best way to almost talk about social determinants of health, is through these group discussions. And as you said, you get everyone's experience, and everyone experiences these social determinants differently and has their own sort of upbringing, and that reflects in their values and their views. So I think that's a good way of discussing it.
Yeah, definitely. And then I guess one aspect of this conversation is, what do we kind of formally learn at medical school? And see, education doesn't stop at medical school. You still continue to learn and have this formalised teaching as a trainee. But I guess I'm interested with you, Mikhail, starting as an F1. How did that teaching at medical school, how have you kind of put that into practice as an F1, or have you been able to, or have there been difficulties with that?
Yes, I guess in the lead up to the podcast, I was reflecting on this quite a lot, and I feel like I've had quite a lot of teaching, and I sort of know quite a lot about the social determinants of health. But actually, because of that, and then you hear these statistics that are so staggering, you think, maybe I'm not going to be sort of perpetuating these. And so the social determinants aren't necessarily at the forefront of my thinking when I meet patients. But I think, reflecting on that, it's almost a bit irresponsible, because I know these facts, and if you're not actively thinking about your own biases in your clinical learning and sort of reflecting on why these issues are systemic, you're not really addressing them. So I think going forward, having had this discussions that we've had today, I think it's going to be a much bigger part of my practice, because I know the theory, and it's sometimes difficult to translate all that theory into like actual your experiences with patients on the day. And I think, as I said, we had these individual days where we'd speak about it, but they almost felt a bit pigeonholed and like less sort of integrated into the themes of the medical degree. Like, I guess we were talking about sort of social history is really important, but with a specific emphasis on the social determinants, I think is more separated rather than throughout the degree.
Affects everything.
Exactly.
Really. It's not just a kind of thing we can just compartmentalise. And I guess, I don't know how much you guys have experienced this yet, but working at different hospitals and between different departments, different places have a different level of workload and also have different demographics. So you see it, and I've felt in my practice you have a bit more time and a bit more, at some places you have more resources to kind of address these problems, and there can be some disparity between different places. I think one of the things that led me into pediatrics, this is true for other specialties as well, but it really felt like a specialty where there was a real kind of holistic focus, taking the patient as a whole and really focusing on their social side and how we can improve their health by looking at the whole patient. I don't know.
Have you felt encouraged to do that early on in your training?
Yeah, and particularly in pediatrics, which is, I think, what attracted me to pediatrics, and specifically within pediatrics, those kind of adolescent aspects, safeguarding aspects. I've kind of naturally been drawn to them because I feel that's what I enjoy, but it's also where you are empowered to think about those things in a bit more depth.
It's an important word choice. Do you feel empowered to really go into a deep history with a patient? There are quite a few times on placement where I've taken a full history, as we've kind of learnt in medical school, to really go through about a patient's psyche and also what's going on in their home background. For example, I wouldn't pass my end of year examinations if in front of the examiner I didn't inquire about the patient's smoking history, alcohol history, their social background, who's at home in their work. When I try and present this to a consultant, for example, on surgery, I've been told, no, I don't need the additional fluff. Give me the salient points. And you start to see this kind of style being perhaps like, oh, am I not supposed to inquire about this nature of information from the patient? Is it no longer relevant? And in pediatrics, it is considered relevant, but perhaps for different specialties, I'm being taught that it's not.
And I mean, to be honest, even there's something to be said for workload as well, because when you have many, many patients in A&E and you're responsible for a lot of them, how much can you go into, a lot of depth with social history? How much do you need to? There isn't one right answer for every case, and people come with different presentations. So I think that is one of the challenges. How much what you learn at university do you then actually apply clinically?
Yeah, and I guess I've just come off an acute med job, and we'd spent a lot of time on the take, and you'd get a lot of patients that came in that were homeless or had sort of drug and alcohol issues. And I know in my hospital there's a really good inclusion health department, so we'd flag these patients up straight away to the inclusion health. And sometimes I guess I'd think maybe we're not best placed to deal with it. It's the skills of the inclusion health, but that's also often we're the first point of call for these patients. We're the first people that they encounter, and we're in a position of sort of trust for the patients. So I think, again, it's sort of our duty to explore that a little bit. And I don't think you can understand a patient without knowing their whole social context. And if you've got time to do so, luckily we were quite well staffed, so you did have a bit more time to explore those social issues. And I think that allows you to give better care to your patients. But I think maybe it is taking a bit more responsibility as doctors if you do have the time, but also working as part of the MDT with the inclusion health teams when available, and the drugs and alcohol teams as well.
Yeah, because I guess that's something to be said as well. Does every hospital necessarily have an inclusion health team? And what kind of services are available at different places? Because as the doctor, you're obviously using the MDT and working together, but in terms of health, you have this oversight, and so many of these other social issues have a direct impact on health. For example, working in oncology, I was looking after people who were staying in hotels, like asylum seekers, and what is the impact of them having chemotherapy and their immunosuppression? How can we think about this? Because this is a social issue, housing. Or, for example, children who keep on coming in with asthma exacerbations and there's mold in the house. This is a social issue, but it's having a direct impact on their health. So I guess this is why it's so important to work together as an MDT, but also to have that oversight and to think about these things.
I think it's now time for doctors to work cross-industry. Like you said, we need to take into account patients' social circumstances, how it impacts their health. But we want to find out how we can improve their access to housing. Is that now part of what we do? Or do we have to communicate with other governmental departments about what we need to happen for patients? Because otherwise we're not going to have an impact on their lives.
I mean, I think it can be difficult if we sort of stretch ourselves too thin, if we're doing that as well. I think it's important to maybe flag to the MDT and other members that can help facilitate that a little bit more.
Yeah.
I think it's important to maybe get the history and understanding, but I don't know if we're not best placed to find them at home specifically, and that's where the rest of like social care and things need to step up as well and help out.
But then I guess it is also important to acknowledge how much power we do have, as maybe power is the wrong word, but how we can advocate for our patients as doctors. I have a friend who works at a refugee centre in West London, and she always says how much of a difference a letter from a GP can make, and we don't realise that impact, but us just kind of writing a simple thing, advocating for our patients' needs can have an impact in a way that other social bodies might find difficult, and that is something that we can help with.
I really like to see that in training posts. So when going into foundation year rotations, I would like to feel like my learning is consolidated following on from medical school. I want to feel more equipped to address these conversations with patients, because right now I feel like I have the vernacular and my vocabulary in terms of approaching the subject is adapt, but I don't know what to do from that point on. So as a GP, when you're discussing with someone about housing issues, I'm not sure about how I can help them, perhaps learning about what we can do to advocate for our patients, for example, writing the letter to the council, or where we can kind of place our power, to use your words, about how we can lobby for our patients, because it's not about just being an advocate in the hospital. To focus on social determinants of health is to kind of also be with a patient, like a team member in their life, perhaps. So do you find in training that you're kind of encouraged to think further about the patient's background?
Yeah, I guess. So as I said earlier, we've had a lot of discussions about sort of the theory behind the social determinants of health, but I think there's less emphasis on implementing those. Like, I don't know if we have the strategies, open-ended questions about social history, but specific examples of how you'd go about exploring those issues, I think there's less emphasis on, and I haven't had much training since I've been in F1. I was looking up on this and someone had like quite a nice way of bringing it up. They'd say, so what are your healthcare goals? I mean, I think firstly that's a good question because it's patient-centered. And then asking what are the barriers to achieving those goals, and looking at, I think that's probably something I'll be able to ask, and I think that opens up the question. But I think we don't have enough formal training of implementing like all the theory behind these things, and that's ultimately the most important thing.
Yeah, I think there definitely is a room to have that training more formalised. I mean, in paediatrics, we, part of a North Central London teaching, there has been formal teaching on, for example, air pollution, safeguarding, contextual safeguarding, but it really is something that is relevant for every specialty. And I don't remember there being any teaching when I was in F1 or in F2 as part of the kind of routine programme, and I think that would be something that would be valuable. Also, just thinking in terms of our portfolio, I know we already have to do a lot, but, for example, in paediatrics, you have to do safeguarding, CBDs, case-based discussions, as part of your kind of yearly things you need to do. And I wonder whether there would be some use doing that in terms of other specialties, kind of a reflection on thinking how social determinants are having an impact on a particular patient you've seen. Is there any way that maybe your TPD or your supervisor would be able to kind of help you think about social determinants, or anything that could happen in practice, do you think, as an F1 or going into F2?
I think, so I love what you're saying. I think the PDP would be a good thing, but at some of the time I think with our portfolios, some of it is just box ticking, and I found also with, for example, when we had the teaching in medical school, we had like 1 million facts to learn for our exams, and then we had this day of talking about social determinants of health, which, if anything, it's more fundamental to how we treat our patients, but it's not assessed as well. So I spent less time focusing on that. I was learning like the minutiae of medical drugs, and I think also changing the emphasis and making it a bit more important. And in terms of the supervisor, I think, it completely depends on your supervisor. Some supervisors, the doctors who were speaking earlier, they're obviously very in touch with the social determinants of health and are great role models and advocates for social determinants of health. But some clinicians, don't have the training or just aren't necessarily as involved with it. So I don't know if the supervisor would always be the best person.
Yeah, and just having to think more broadly about holistic healthcare, do you think that is achievable and something that you feel empowered to do? Maybe you, Mikhail, as an F1, but also you starting F1 soon. How do you feel about going into that and being able to kind of think of the patient as a whole?
I think throughout the development in medical school, they've given us plenty of opportunities to understand and appreciate the nature of holistic medicine. I have never gone into an MDT without understanding that everyone's voice should be heard, to think about the different aspects of patients' life. That kind of conversation is so vital in creating a management plan that's so specific and tailored to a patient that it's almost like the gold standard of medicine. I'm kind of perhaps growing up in a golden age of medical school where there's an understanding about really getting into the nitty-gritty in the background of a patient to kind of help them push forward. To me, that seems like the perfect way to operate, and it's very sad to hear in the circumstances, for example, when job working hours are strained or when you're tired, that you aren't able to do that. I feel very equipped to advocate for that kind of practice of medicine, but I don't know how that translates yet with reduced, like with working hours and with constrained understaffing. Do you see that as being possible?
I mean, ultimately, I think it is possible, and it has to be possible. And I think Marmot said something about how if all policy was made focused on social health care at the heart of every decision, I think that would probably help with these things. But in terms of what you said earlier, the MDT, I think that's really useful. Other people have different skills to bring to the table. But I think, me personally as well, I think some doctors should be a bit more empowered about the role that they can play in understanding the social determinants of health as part of the MDT. And I think that's something I'd like to take forward as well.
Yeah. I wonder also whether we're maybe a slightly self-selected group in ourselves. Do you find that your attitude towards holistic care and kind of the training you've received at university, is that something shared among your cohort, or are there kind of different levels of engagement?
I think there are different fashions with medical school every few decades, and the way that in which they select the students through the MMI process, we have to kind of mimic being doctors, and they want to see the style in which we communicate with patients. So I think this is a fantastic cohort that really do take into account different aspects of the patient's life. I think we're more forward thinking and holistic now than we've ever been as a student cohort. So I'm really looking forward to kind of working with colleagues who have that kind of appreciation. Do you find that in your cohort as well?
Yeah, I'd say definitely more so. I mean, having discussions earlier with some of the other doctors, I think they've had less exposure to these sort of things. But also, when you're going into the hospital as a bright F1, you've got these ideas about how healthcare should be, and then you're in a system that doesn't necessarily cater for that. The environments are quite senior-led, and sometimes as an F1, it can be hard to advocate for those issues, and you almost sort of slip into the mould and follow the systems that are already there. And I think that hopefully the culture will change over time, but I guess these issues are systemic within the culture, and education is the best way of breaking that, and our hopefully younger generations with more training on it can help facilitate those discussions.
To be honest, it sounds like you're in a great environment at university, and there's so much learning that we can take from other students, other doctors, and I've really appreciated our conversation today. Thank you for coming. Just to recap what we've spoken about, it sounds like there have been a lot of improvements in how medical schools have engaged with teaching about social determinants of health, and that's really great to see. But it's also important to think about how does this translate into our clinical work, especially with clinical pressures, and how can services kind of empower a new generation of doctors to take their learning into practice. But yes, thank you to the college for having us, and thank you to Mikhail and Josie for joining me.